Good day, everyone. My name is Boyan Korda. I'm an anesthesiologist and critical care fellow, assisted today by Donovan Hessop, one of the registrars. Today, in Airway Month, I will be doing a short primer on gastric ultrasound. First thing you need to know is when to do a gastric ultrasound. This is not indicated if the patient is known to be high risk for aspiration, such as a patient with known bowel obstruction, nor is it to be used for patients known to be low risk. Instead, it is intended to help risk stratify patients with unknown risk. This can include patients such as those with a lack of adherence to fasting instructions, for example, before emergency procedures or due to miscommunication. Those patients with an unreliable or unclear history, such as pediatric patients, patients with a language barrier, patients with some sort of pre-existing cognitive dysfunction, or where there's a potential delay in gastric emptying, such as diabetics with some degree of autonomic neuropathy, or patients with renal dysfunction.
How's it, guys? Today we're going to be doing gastric ultrasound. Don has very kindly volunteered to not eat this morning so that we can do it with an empty stomach, a stomach full of fluid, which we'll show you second, and then a stomach full of pasta. Yeah, right. So just so you understand, gastric ultrasound is a tool that's sort of been developed to assess the volume and quality of stomach contents, and that then determines whether we should be doing a intubation with aspiration precautions like an RSI, or whether we can proceed with an elective sequence induction. The kind of probe that we select is a curvilinear probe. You can put it on an abdominal setting. And yeah, there's two views that you need. I'll show them on Don. Don, can you show us your abdomen? Right. You will be able to see the videos of the slides themselves in a second. Alright, so you start in the midline in a cranial to caudal direction. And the important thing is to get a view of the liver, the stomach, which is there, but that's the last thing you notice, and then the actual aorta. So here, this is the IVC. It's very easy to go off axis. The way you know it's the aorta is because it pulsates and it doesn't go into the heart. Okay, it doesn't ascend into the heart. And often above the aorta, you can also see this, which is the superior mesenteric artery. Okay, and on that, I'm just zooming in just for purposes there, you will see this 5-layered gastric antrum. Okay, this is an empty gastric antrum. Once you've done it in the supine position, you cannot say that the stomach is empty. If, however, it's full here, you can then stop and say the stomach is full. The next step is to make the patient go into a right lateral position. So John, you can do that. Perfect. Okay, and then you have to find the same view. Sometimes you can get air getting in the way here because of the transverse colon, which can be full of air. All right. So sometimes what you have to do is you just have to gently push and wait for that to move out of the way, all right? Again, you get the same view with the aorta and the liver, and you can see the gastric antrum here. Again, this air is from the transverse colon, all right?
So many people struggle to translate the black and white pixels we get on ultrasound to meaningful information. So I want to spend the next little while helping you understand what we see in these pictures. Again, we choose a curvilinear probe and put it in the midline to get a slice through the gastric antrum. If we were to do a CT through this plane, you would get this sort of picture with the antrum here shown with an A. Other points of interest not discussed further are the pancreas, shown with a P, and the transverse colon, shown with a C. These are not always easy to identify on ultrasound, but are occasional mimics of the gastric antrum we might have to avoid. So that's what we are meant to be seeing, but how do we actually know what is what? Here's a short clip taken of Don's abdomen. Take a look and try to identify the structures. Right, so the way to do this is to sequentially identify the following. First, the liver, shown here in green. It is always below the diaphragm and the closest and largest organ present. Next, the aorta, which has a thick wall, is pulsatile and is not continuous with the right atrium. It also has the superior mesenteric artery arising from it,
before the SMA turns caudally to supply the midgut. So you can see it here coursing parallel to the aorta. Finally, the gastric antrum, shown in yellow, is found just below the liver and has characteristic layers that make it the most complex structure actually present. These layers are actually more apparent if the antrum has some contents within it. If shown in another axis, the different gastric layers of the antrum are the serosa, the muscularis propria, the submucosa, the muscularis mucosa, and the mucosal interface. This is the only GI structure with so many layers apparent on ultrasound. Here is another annotated diagram for you to look at and study. Okay, so now that we understand what a normal empty stomach looks like, let's proceed to show you how it changes with some clear fluids. Alright guys, so Don just had a whole bottle of Energate. Let's see if there's any difference on the sonar. So again, we start off supine, and if that is positive for fluid, you would not proceed with an elective sequence. Hold it there. Alright. Okay, same thing, midline, you try and find the aorta, which is going there, and you see liver, and below that is this complex structure, which you can now see is much fuller. Okay, Don, will you turn for us to the right lateral decubitus position? Just to show you guys that it stays, and you can now see it's massive. Okay, that's 500 mils of fluid. You can do a cross-sectional area, which I'm not going to show you now, and then you actually can use a formula to work out what the gastric volume is. Thank you, Don. Okay, so can you spot the obvious differences compared to the last image? Again, first identify the liver. Here it's shown to be quite small in the top left corner. Then the aorta plus minus the SMA. And then finally the antrum. Notice the hypoechoic enlarged central cavity representing the clear fluid Don just consumed. Again, here is another diagram to help you understand the anatomy shown. Finally, Don eventually gets to have his breakfast, a lovely pasta that was the leftovers from dinner the night before, as well as the chocolate I bought him to combat his hypoglycemia. Alright guys, so Don's had his lunch, so we're going to show you what the stomach looks like now. Again, we start in the exact same position, using the same probe. Okay. And you can see now, there's the aorta, there's the liver, and now there's this bigger structure here. I'm going to just zoom in on it. Okay, you can still see it's got multiple layers, but you can see it's got some shadowing. That's because there's air that he swallowed along with the food. Alright, I'm going to save that. It's actually a really nice picture because you can see the 5 layers of the stomach there, and you can see the shadowing behind it, so you don't always see the aorta behind there. Now John, you're going to turn for us to the right lateral decubitus. If I saw this, I wouldn't bother making the patient turn because that stomach is full. But here, just for learning purposes, I can show you how big that stomach gets. Alright, and you can see it's now taking up, but the majority of the screen is a lot more shadowing. And there's the liver. So if you see this, the stomach is full, you can't proceed with an elective sequence induction. Okay, looking more closely at these images. Again, start by identifying the liver, then the aorta and SMA, and then the antrum. Notice how the hyperechoic enlarged central cavity now has this shadowing behind it. You cannot see the back edge of the gastric antrum because the air consumed with the food creates shadows that obscure it, as well as any structures posterior to it. This is a full stomach, and if the patient is induced, there would be a high risk of aspiration in this case. Again, another alternative diagram to help you understand the anatomy shown. I let Don go off to do the ICU round, but called him back 2 to 3 hours later to see how things have evolved. This is a short clip of the repeat gastric ultrasound in Don. Notice now that the air has been worked out of the ingested food. There is no posterior air shadowing, but the antrum is still clearly distended. Looking at a still image, we again start by identifying the liver, then the aorta and the SMA. And then the antrum. Notice how the hyperechoic enlarged central cavity, now with a visible back edge to the gastric antrum and structures posterior to it. Again, this is a full stomach, and if the patient is induced, there would be a high risk of aspiration. Finally, another alternative diagram to help you understand the anatomy shown. All right, just a few tips. Always have a clear sequence, which we've shown you today, to help you identify structures. If you struggle to find the antrum in one position, find it in another, and then keep looking at it whilst the patient turns to the hopefully right lateral decubitus position. And finally, the stomach is unique in that it has multiple layers. If you don't see them, you're probably looking at the wrong structure, either the transverse colon or rarely the pancreas or even the gallbladder. Here is a summary of the different qualitative appearances on sonar of different types of stomach contents. And that's it. We hope you enjoyed the short primer. Most of the images used are from a wonderful resource on this topic. The link provided on screen takes you to it. There's a lot more to learn about this topic, but the only way to start is by practicing. There are more advanced applications and special patient populations with specific considerations, but these can be discussed at another time. Thank you very much for listening.